Evening, EDIC Part 2 aspirants and our honorable faculty, Dr. Akhilesh Tandekar. He would be conducting today the class of Obstetric Emergency. So he is Head of Department in Critical Care at Apollo Multispecialty Hospital at Mumbai. And his area of interest is in DNB Critical Care, IDCCM and IDCCM. Over to you, sir.
Thank you very much for this introduction. Today we are going to discuss a very important topic, not discussed too much frequently, but this is very important as far as EDIC exams are concerned. So the better understanding of this obstetric emergency is the core, is one of the core competencies nowadays, and then we have all realized that, maternal mortality has significant impact. And that has definitely led to the importance of better understanding of obstetric emergencies. Today, I'm going to discuss about obstetric emergencies in ICU, and you all are aware that it is one of the important topic which is a nightmare for few people, students or those who are not exposed to the obstetric critical care. So it becomes difficult, but you should have a theoretical understanding, and we should also gain the practical experience. Today, I'm going to discuss in these obstetric emergencies these important issues. So I'm going to talk on hemorrhagic shock. I'm also going to highlight about eclampsia, preeclampsia, peripartum respiratory distress, pulmonary edema, ARDS, peripartum cardiomyopathy, liver failure, and HELP syndrome, and ultimately I am also going to discuss about CPCR. So these are the occasions where the intensivist will be called for, and then we should be able to deliver the job to the best of our ability, as we intensivists are supposed to have good understanding of the obstetric physiology, pathophysiology, and then the management and the diagnosis. All these are important, important expectations as a clinician from the obstetricians, because obstetricians, their knowledge is limited to probably the obstetric part only. But the emergency care, probably they need the help of the intensivist, and we should be able to do justice. So first, I'm going to talk about shock. The shock can present in either prepartum or postpartum, and then peripartum hemorrhage there are different causes. We are aware, like abruptio placentae, placenta previa. These are the peripartum causes of hemorrhage. But postpartum also patient can have extensive hemorrhage, and usually we all are aware that vaginal delivery is associated with blood loss of around 500 ml. And in cesarean section, the blood loss can be as high as 800 to 1000 ml. And in hysterectomies, the blood loss can be a maximum up to 1500 ml. And if we are going for emergency hysterectomies, cesarean section with hysterectomies, in that situation, we may face a blood loss of around 3000 liters. So when you are dealing with postpartum hemorrhage, so any of these surgeries can lead to significant hemorrhage. And the commonest cause, as I've already discussed, the antepartum and postpartum, the abruptio placentae is very notorious to cause a concealed bleeding. And then it may not be identified till there is obvious bleeding. And it can lead to significant blood loss of around 1000 to 1500 ml if it is not identified quickly. And abruptio placentae is also associated with the disseminated intravascular coagulation. So there is a coagulopathy along with this hidden. So that's why, the patient has to be resuscitated well, and prompt intervention, timely intervention is also very important. So uterine trauma is also associated with significant blood loss, and placenta previa is also one of the antepartum causes of hemorrhage. Postpartum, these patients may have retained placenta, especially when there is uterine atony and the placental bits are retained inside. That can also lead to continuous bleeding. And sometimes due to over distension of the uterus or excessive manipulation or excessive uterine contraction, it can lead to uterine rupture and can lead to significant blood loss. And then during the surgery, there can be lacerations and it can be associated with significant case fatality. So that's why we should be very, very cautious when we are, handling obstetric patients. And coagulopathy is the major threat, especially with HELLP syndrome and patients with 𝐓𝒃𝒄. These patients who develop coagulopathy and they are at risk of developing coagulopathy, and prompt intervention for control of coagulopathy is also very important. So what are the principles of the shock management? The shock management is similar to any other shock, whether it is hemorrhagic shock or shock associated with a trauma. The management is aggressive. It has to be aggressive, and we should not wait till the patients have significant blood loss. Obstetric patients have large volumes. Even if they have 25 to 30% of blood loss, okay, they may not become symptomatic because they have significant hormonal support, protective, physiological, changes that may help. But but if the blood loss is significant enough, okay, these patients should be will be decompensated, because during pregnancy there are a lot of compensator mechanisms which are active. When the patient becomes exsanguinated, these patients rapidly deteriorated because the compensator mechanisms also fail. So we should not wait till the compensator mechanisms fail and patient is in significant shock and then address. So preemptive assessment of the patient in terms of severity, early diagnosis with different gadgets, ultrasound, and clinical examination is also very, very important. And then the diagnostic laboratory diagnosis, low hemoglobin, low hematocrit, will also give us enough idea that the patient may be in hemorrhagic shock. And then, the management of shock is also little altered. You can't give lots and lots of fluids. Okay, that will again cause a lot of problems. The blood should be replaced by blood, and blood products also should be given in 1:1 ratio, especially when we are dealing with massive transfusions. So let me start with the case presentation. It's always good to have a case, and then the understanding becomes easier. So this is one case, 22-year-old female patient presented with PRIME and 40 weeks of gestation. She was diagnosed as PIH, and at the age of at 23 weeks of pregnancy. So pregnancy-induced hypertension was earlier diagnosed, and ultrasound abdomen showed intrauterine fetal death. And then this patient underwent termination with misoprost 50 micrograms, but there was no delivery. And then Ventu was applied, episiotomy was tried, and all these attempts failed. And then patient was ultimately decided to take for the cesarean section, but patient remained exsanguinated, and the PV bleeding continued. Patient received 1 unit of blood and 500 of hemacil, and the patient was shifted to the ICU accompanied by a doctor. So, so many a times we see what we see externally may not be the true picture. Okay, we just see the tip of the iceberg. Okay, so young patients, they have good compensating mechanisms, but there may be an internal concealed bleeding which is not identified until the patient gets completely exsanguinated. So that's why it's just the tip of berg, which we should not rely. We should have extensive clinical examination, laboratory diagnosis, and in imaging modalities also should help us to identify the problem. Just by looking at a patient, sorry. So just by looking at the patient, on his face is not enough. You have to have thorough head-to-toe examination, and then early involvement of the obstetrician and assessment of the patient for ongoing bleeding should be a continuous process. So we should always keep thinking about ongoing bleeding, and the corrective measures should be advocated. So we at times underestimate, because obstetric patients will not present with low blood pressure till they are decompensated, or these patients will also not present till they have extreme hypoperfusional state, or they have extreme hypoxemia. So this is because of the metabolic disarray that we see. So just by seeing the blood pressure is not enough. Okay, when the patient is exsanguinated, they will have hypoperfusion and they will have signs of shock. So the protocol has to be followed up. Okay, and then we should also have the understanding of the shock. How does the shock present? So whenever the patient is hypovolemic, the preload to the heart is compromised, and the heart as a pump fails. And as the heart is the main organ which supplies blood to all the organs, there is impaired perfusion of all the tissues and the organs, and there will be tissue injury, and as the capillary perfusion will be compromised. And when there is tissue injury, there will be anaerobic metabolism, and extensive release of inflammatory mediators will lead to systemic inflammatory response. And that exaggerated systemic inflammatory response is the major threat and is the cause of organ dysfunction and organ hyperperfusion. So as far as the ill effects of shock is concerned, shock will present with metabolic acidosis. Patient will be breathless, tachypneic, acidotic breathing also will be seen. They will also have cold clammy extremities when they are exsanguinated. Some patients also present with edema, lung edema, especially when there is myocardial depression. Okay, these patients can present with pulmonary edema, and they will have respiratory distress due to excessive fluid accumulation, or due to extreme systemic inflammatory response. There will be a lung injury, and patient can also present with features of ARDS. And due to exsanguination, if the blood supply to the brain is compromised, these patients will be irritable, agitated, which are the signs of cerebral insufficiency. And the kidneys are the last organs to be affected. Kidneys will keep perfusing, keep managing, keep compensating for the insufficient status, and ultimately, if there is a significant hypovolemia or low blood pressure, kidneys also get suffered, and ultimately the intestine also gets affected, and there will be hypoperfusion of the stomach, and the patient will present with vomiting. If the patient is presenting with vomiting, it means there is significant intestinal blood flow compromise. So we should not delay. So many times, the obstetric patients, their clinical findings may not match. And then we get fooled by the appearance of the patient, which seemingly they look normal. But inside, there is something which is going on. The compensatory mechanism is going on, which keeps the patient stable. But later on, once the compensatory mechanisms fail, these patients deteriorate rapidly. So that's why our anticipation of the problem and understanding of the pathophysiology of complications associated with obstetric emergencies is very important, and we should have willingness to advocate urgent surgical interventions, early institution of fluid, early institution of blood and blood products, or control of the hemorrhage will be the mainstay of the treatment. And correct diagnosis is also very important. Okay, we keep on gazing at times, and we lose a lot of time. So that's why a prompt clinical examination and correlating the clinical findings with laboratory parameters is also very important. And the imaging, ultrasound, the Dopplers can also give us enough idea about what's going on in the patient. And then we should not hesitate calling for the help, and then early referral to the specialist and higher care centers are also very, very important aspects of the management of obstetric emergency, because at village level or community hospital level, if the patient is presented, and if we don't have the gadgets, so if the patients are retained for a long time and they have not received appropriate treatment, and they transfer to the definitive sentence is delayed, these patients will die during the transit. Earlier, there used to be a lot of deaths during transit, or, early medical help was not given to a lot of patients, and they used to die, and then maternal mortality was very, very high. But now the maternal mortality has come down with the early intervention, early diagnosis, and early referral to the higher care centers. Though we have been able to reduce maternal mortality. So when the patient came, the same patient came, okay, if you want to go through the case again, okay, I will go back to the case. As you know that this 22-year-old female patient with 40 weeks of pregnancy, this patient was advised to undergo termination of pregnancy. Okay, misoprostol was also tried, and then Vento was applied, and this patient had PV bleed, and he was in shock and received blood transfusion. So this patient was transferred to our hospital, and to our surprise, what was told to us. Am I audible? Any issues?
Same route.
Can you mute those individuals who have kept their mic on, please? So this patient came to us in a drowsy state and hemodynamically unstable. What we were told about just one blood transfusion, and patient was probably a little stable, but during transit the patient deteriorated. He became drowsy, means patient had significant cerebral hypoperfusion and hypotension. So immediately the patient was intubated in the ER, ventilated. Immediately we tried to arrange blood. Cross-match was also sent, labs were sent, and colloids were instituted rapidly. And patient was catheterized, and we saw that patient had hematuria, and we thought that this patient may have coagulopathy. This patient was full term, and the uterine contour was well filled, and episiotomy wound was also there, which was bleeding continuously. Patient was fully dilated, and if cervix was effaced, but the but the baby had not shown descent. And in view of hypotension, the patient received a dopamine infusion, and with a 70 systolic BP, patient was shifted to the ICU. So what is more important in such situation is ABCD. Okay, ABCD approach, which was followed earlier, and then which has been changed in 2010 to circulation should be given a priority, and then airway, and then breathing. Most of the patients, they die because of inadequate circulation. Okay, so early control of circulation. Okay, if the pulse is not palpable and responsive, early CPR can also be initiated. But if the pulse is feeble, early institution of fluid. Volume expansion is the mainstay of the treatment, but excessive volume with resuscitation with the fluid is also dangerous, because that will cause dilutional coagulopathy and dilutional thrombocytopenia, and they will keep bleeding. So volume expansion with the help of blood and blood products in the ratio of 1:1 is very, very important. And definitive management is control of the hemostasis. Okay, direct compression is not possible. There are a lot of thoughts pertaining to which crystalloids we should use. Initially, balanced crystalloid can be used, and then normal saline, which has higher osmolarity, can also be used. So whichever fluid we use should be able to maintain the volume intravascularly. So as we know that, now there is a lot of debate amongst crystalloid and colloid infusion. So the colloids, are not recommended, especially hydroxyethyl starch or gelatin. So crystalloids are supposed to be, the fluid of choice in such situation. And amongst these fluids also, balanced crystalloids will be preferred, especially Ringer lactate, and newer preparations are also available. Plasma light and all these preparations will be very, very useful. And then as we know that, so what is the conventional, management? We've always been trying to infuse fluids, but in the bargain, what happens, excessive fluid resuscitation is associated with lot of dilution of the coagulation factors. It reduces hematocrit, and then if the fluid is not pre-warmed, that can also lead to hypothermia. And as we know that hypotension will lead to acidosis, and hypothermia, cold fluids, if transfused, can lead to hypothermia. And then acidosis, hypothermia will lead to coagulopathy. So this is a lethal triad. We should understand that, coagulopathy can be prevented if we use pre-warmed fluids and prevent acidosis. And then massive normal saline infusion is associated with hyperchloremic metabolic acidosis. So excessive normal saline should be prevented. So balanced crystalloid should be instituted, and normal saline in excess more than 1 liter will lead to hyperchloremic normal and anion gap metabolic acidosis.